burning question at this point. I hope you're making notes or questions for the discussion which will follow. We're going to go for about 35 minutes. Is that what you'd like? Perfect. Okay. Any burning questions? Okay. All right, save them for the discussion. Our next and final speaker in the session is Dr. William Winslade, and he's going to speak on human needs, human rights, and access to healthcare for everyone. For everyone.
Our host, Tuttle Jones, thought I might be able to rise to the occasion, but I'm afraid that I can't even begin to make the kind of case that Professor Randall made about racism. I think she's quite right. Most of the things that she said. What I can do, and I'm doing it without any slides, so you have to pay attention, and I know it's hard to do this late in the day, but I've been here for a while too, so I'll try to stay awake if you will. I wasn't going to talk about this next topic, but I think I will, just as a way of introduction. And it's not in any way to disagree with Professor Randall, but rather to point out that discrimination isn't limited to African Americans or to anybody. We are all potential victims of discrimination in different ways, and many of you have been following the saga of Sarah, the 10-year-old girl with cystic fibrosis that needed a lung transplant. Most of you followed this at all? No? Well, I'll make it simple. For a long time, she has had cystic fibrosis. In fact, she's 10 years old and she had it from birth. And one of the things that we know about organ transplantation is that cystic fibrosis, now because of the technology of transplantation, can be actually cured by a transplant. In the United States, the rule for access to a transplant is first, those who are most needy, have the most medical necessity for a transplant. And that rule has replaced the old rule that gave a lot more weight to how long a person had been waiting for a transplant. I'm not going to argue whether transplanting the most medically needy is the right rule or not, but that is the rule. There was no question that Sarah, the 10-year-old, met the medical criteria for being the most needy person waiting for a lung transplant in her region. But there was another rule. The other rule was that if you're under 12, then you have to wait until people who are older, even if they're not as needy as you are, get a transplant before you can get one. This is the loosely called the under 12 rule. And then there are different rules for other age groups leading up to adults. But the point was that somebody much less needy than Sarah, but medically appropriate for a transplant, would get a lung before she would. Finally, her parents brought a lawsuit, federal court. And the judge in the case said, wait a minute. You shouldn't discriminate against her because she's under 12. That's an arbitrary form of discrimination. If she is medically appropriate, if her body is such that she can hold an adult lung or even an adult lung that's been shaped for a child, she should get the transplant. The Secretary of Health and Human Services took the judge's suggestion that they make an exception for her give her the first available lung in that region. So she ordered doctors in the region to do that, and she got her transplant because the court issued a temporary restraining order against implementing the under 12 rule, and now they're reconsidering whether that rule is appropriate. This is just a simple example of discrimination that didn't make any sense because they didn't have good reasons for it. It's going to take a lot more to do something about many forms of discrimination. Trust me, this is water, not vodka. But I might wish it were vodka. And if I were in Sweden, it probably would be vodka. I spent some time in Sweden. Listen, you don't want to be in Sweden in the wintertime because you have to start drinking very early in the day because it gets dark so soon. All right. I gave you the example of Sarah just to point out that that's just one tiny example of health disparities in the United States. What I'm going to be doing now in the time that I have, and I will have my clock in front of me, is give you an overview of some of the ethical issues that I think we are all confronted with and we haven't solved by any means. As you all know, the healthcare system in the United States is based on a curious mixture of private insurance provided by employers, insurance purchased by individuals, federal programs like Medicare, state programs like Medicaid, funded in large part by the federal government, child health programs, and self-pay and charity care. Millions of Americans do not have insurance and do not qualify for federal programs. In Texas, where I've lived since 1984, with increasing bewilderment at the wisdom or lack of wisdom of the legislature and what apparently is going to be the perpetual governor of Texas, there are 5.8 million people in Texas who are uninsured. They will not be helped by the Affordable Care Act. And those who would have otherwise qualified for Medicaid by the expansion of Medicaid won't be helped in Texas because Texas isn't willing to make the Medicaid expansion. It might cover another 1.5 million, still leaving a large number of people uninsured. The governor, in his wisdom, turned down about $100 billion worth of federal funding for Medicaid expansion that would have cost the state of Texas about $15 billion over that same period. I want to read something written just recently in a blog by a former student of mine who teaches now in Chicago. And he grew up in Texas. His father was a physician in Lufkin, and he went to school here. Keon Parsi, who is a lawyer and has a PhD in medical humanities, says the following. I recently learned that my home state of Texas has refused to participate in Medicaid expansion that is part and parcel of the Affordable Care Act. When I first heard this news on NPR, I nearly gasped in disbelief. Governor Perry and the Texas legislature will walk away from $100 billion of federal money to help the state's poor, elderly, and disabled. Wade Goodwin, the NPR reporter for this piece, went so far as to state that, quote, Texas Republicans have moved steadily to the right, to where the very concept of public health insurance or any kind is looked at through narrowed eyes. The public perception of Medicaid is that it primarily covers the poorest of the poor adults. In fact, children account for Medicaid's largest percentage of enrollees, and the largest amount of spending goes to the blind and the disabled. Yet any expansion of Medicaid in the service of Obamacare is viewed as an expansion for the undeserving poor. Texas has a distinct status of having one of the worst safety nets for the poor. Unfortunately, this latest move by the Texas state legislature and the Texas governor undermines an already weak system. There it is. Lots of people have reported about it, but Kehan said it very clearly. What I want to do is get to, in my conclusion, what a full access healthcare system would look like and why we ought to have it. I'm going to make an ethical argument with a nod in the direction of the law, but mostly an ethical argument. Let me just state a fact. Nearly all industrialized nations have some form of universal access to health care. European nations, Scandinavia, also Taiwan and Costa Rica. So it isn't limited to industrialized nations. I'm going to argue that universal access to health care based on vital needs should be based on vital needs and social responsibility. And I will also explain why universal access to health care, which is, as some people have said, is generally favored by many Americans, has not been achieved in the last century in the United States and is not likely to be achieved in the near future, despite President Obama's efforts to expand health care coverage. He buys into the insurance coverage model, which is not access to health care, it's access to insurance. I think it's crazy. I like it even less than you do, if that's possible. Now, I want to recommend a book. Unlike my colleagues who recommend books they like, I'm going to recommend a book I don't like at all. But I think you should read it with a critical eye. It's called Power, Politics, and Universal Health Care, written by Stuart Altman and David Shackman, with a foreword from Senator, now Secretary of State, John Kerry. They do a wonderful job of telling you why we don't have universal health care in the United States. And then toward the end, they sort of say, well, but we're on the way to it. And I think that's crazy. I think we're not on the way to universal access to health care at all. We might be on the way to universal rules requiring insurance, but that's not the same as access to health care. So, although this book is useful in telling us why Nixon, Clinton, Carter, and others before that, Teddy Roosevelt, failed to establish universal access to health care in the United States. To get to my conclusion, I want to say just a little bit about the concept of health, which is badly mangled in some of the official statements about health care. And I'm going to say some unkind things about the World Health Organization as well as the Universal Declaration of Human Rights. There is no question that health is special, and that we need decent health to survive. But we also need food, clothing, shelter, other things. And if you have bad health, it interferes with, but doesn't necessarily preclude learning or succeeding tasks or a career. It interferes with quality of life, and it interferes with our ability to flourish as persons. But here's what the World Health Organization says about health. They say, and you've heard this before, but just think about it for a minute. Health is, quote, a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. Come on. That isn't even a realistic aspiration, much less a definition. This definition is confusing because it conflates health with complete well-being. How many in this room are experiencing complete well-being? Nobody's healthy here. Not according to the WHO. This definition is at best an aspirational ideal. Or maybe it's just a fantasy that is so unrealistic that it may seem like empty rhetoric. That's kind of what I think. But we can salvage some of these ideas by viewing health, indeed, as the absence of disease or infirmity. Health health is a condition that promotes well-being, happiness, flourishing. But even persons with poor health or infirmities can flourish. We know that. Think of Stephen Hawking with his infirmities. It doesn't stop him from flourishing. It interferes with his quality of life, but he functions. Think of Helen Keller. Think of anybody you know that lives effectively with blindness or an amputation or other kinds of conditions. So let's be conceptually clear. Good health is helpful because it helps people to pave the way for human flourishing. But it is neither necessary nor sufficient for human flourishing. It's just a positive contributor. We hope for good health. We can act in ways to try to sustain it. We sometimes can restore health by health care. All of that's true. And indeed, health is in one sense a vital need. But most of us enjoy a reasonable degree of good health. At any given time, we are all, every one of us, vulnerable to health problems. And what we need is, at the time we're vulnerable, to have access to something that will help us overcome the problems. So let me turn to the Universal Declaration of Human Rights, which was passed in 1946. I quote, "Everyone has the right to a standard of living adequate for the health and well-being of himself and his family." How we would say, health and well-being of persons. It's another aspirational ideal or a fantasy, but it's extremely unrealistic, just like the World Health Organization definition of health. So how do we get from a real need for health when we need it to a right to health? And here I'm going to allude back to our first speaker's comment. What we need, but I will argue don't have in the United States, is community solidarity. No question in my mind. I've been to Sweden. I lived in Sweden for several months. I've traveled in Europe. As far as access to health care, those countries have it all over the United States. Even Germany, which has a compulsory insurance program, provides universal access to health care for everybody. We don't treat people equally in the United States. I mean, Professor Randall's made it absolutely clear, and she didn't limit her remarks just to blacks. As she pointed out, the genocide against Native Americans is scandalous, horrific, and we need to remember this. My wife is Irish. She would say that the Irish haven't overcome their limitations because you may like chitlins. The Irish like their potatoes and meat, especially their potatoes. And you can get along, but it's better to eat yams than potatoes if you want to do it for health reasons. So, what else do we need? We need equality and we need justice. And the sense in which we're all equal with respect to health is that we're all potentially vulnerable to health problems. But I want to argue that we all ought to be seen as morally equal with respect to response to our health problems. And that's what universal access to health care will provide. I don't have time to go into the entire details of the argument, but let me just give you, borrowing from somebody I wouldn't normally be borrowing from, physician named Robert Sade, who is actually very much a libertarian. He gives a nice description of what the ethical foundations of social responsibility for providing health care would look like. Here's what he says. I'm going to read a couple of paragraphs. There should be a universal access to health care with no financial or other barriers to obtaining health care services. Losing a job or suffering economic difficulty should not raise the fear of losing health care. Access to needed services should not be denied because of pre-existing conditions, age, race, genetic background, or disability. Barriers to access arising from linguistic or cultural differences, geographic difference, prejudice, residence in economically deprived or underserved areas, or excessive out-of-pocket payments must also be removed. And then he says, and this is the part that will make sense to you, a comprehensive package of benefits should be offered to all Americans. The package should cover primary, preventive, chronic, and long-term care, as well as acute care, home care, hospital care, and treatment for both physical and mental illnesses. And that ensuring fair burdens would mean that payment for health care should be based on ability to pay. That is, the cost of providing for health care needs should be spread across the entire community, and so on. I mean, it's pretty clear. It's a very sensible description. Y'all can understand what he was saying, right? It's not that difficult. Primary care through all different phases of possible health care needs. And as I said, to some degree, it's been achieved, although not completely, in other countries. Lest you think that I'm only going to say negative things about the United States, we do have some contexts in which there is universal access to health care. Can anybody name the federal law that guarantees, at least in theory, but not necessarily in practice, but in theory, universal access to health care? Pardon? The VA? Yes, for a class of people, it does. It doesn't provide universal access to health care for everyone. But you're right about the VA. In theory, that's what they're supposed to do, provide complete coverage for veterans. Have you heard of the Emergency Medical Treatment and Labor Act, EMTALA? If you show up in an emergency room, regardless of your ability to pay, and I teach one day a week in Austin, so I have a lot of students that don't have any money, but they go to the emergency room and they have to be evaluated. And if they have a life-threatening emergency, they have to be stabilized. That is, in the United States, by law, one of the two forms of universal access to health care, and it's the only one that is sort of definitive. And it includes, in Houston, doesn't matter if you're undocumented or not. If you show up in some hospitals, at least, in the emergency room, you will be treated if you have a life-threatening emergency. Why? Why does that make sense? Because life-threatening emergency, if your health is that bad, you don't survive, that's it. So it's the bare minimum form of access, universal access to health care. But we do have it. Now, does anybody know what the second form of near universal access to health care is that we have in the United States? This is an important point. Anybody know? Anybody heard of end-stage kidney disease? If you have end-stage kidney disease, you are eligible, regardless of your age, to be put on Medicare. And you don't just get put on Medicare to treat your kidney disease, you get Medicare, the same thing that folks like me over 65 get. If you've signed up for it, which I haven't. Because I get it from my employer. So why should I pay Medicare when my employer pays my premiums? I'm I may be silly, but I'm not stupid. But for people with kidney disease, they get access to health care that the rest of us don't get for all of their other health needs. Why did that happen? Well, as Professor Randall says, knowing a little bit about history sometimes is helpful, sometimes it's dangerous, but in this case, it's very important. After Medicare was passed in 1965, the kidney dialysis machine was invented, and they didn't have enough machines for all the people that had kidney disease. So the kidney disease lobby did a dialysis right in front of Congress in 1972, and said, if you don't pay for dialysis for these people with kidney disease, they're all going to die. And Congress, oh my God, this is a survival issue. We're going to pass a law and make an exception for people with kidney disease and let them be eligible for Medicare. And of course, now it's turned out that kidney dialysis is not as effective and not as cheap as kidney transplants. So the government pays for kidney transplants as well as kidney dialysis, which is a good thing for people with end-stage renal disease. But many people have asked over the years, why just kidney disease? There are lots of other potentially lethal conditions that the government doesn't pay for. Well, my point is that in the United States, we have responded at least twice with EMTALA and with treatment for kidney disease to universal access to people with those health conditions. Unfortunately, Medicare, Medicaid, private insurance, indigent care doesn't cover everybody. So there are lots of people that don't have access to health care. And the short answer for the reason that we don't give everybody access to health care is that there's a lack of political consensus and no presence of a political will to do so, even though most Americans think it's a good idea. What I'm going to do is explain why we don't have universal access to health care in the United States. And there are about 8 reasons. And then I will conclude with my proposal for what kind of universal access makes sense. First of all, one of the reasons we don't have universal access is the result of the power of special interest. And there are many of them. In the early years, the AMA was totally opposed to universal access to health care because it was socialized medicine, and doctors would be treated like the doctors in the Netherlands who only get paid a salary. So that wasn't a good idea. Hospitals don't want universal access to health care beyond the emergency room. Even hospitals that are dedicated to the indigent people of Texas, University of Texas Medical Branch, where I've been teaching since 1984. When I went there, that was actually true. Anybody that showed up would be evaluated and treated. That's no longer true at UTMB. It is not there for the health of Texas, it's there for the health of people that can pay or live in a county that has a contract with UTMB. So people, residents of Galveston, who go to a free clinic for certain minimal things can't get into the hospital unless they have insurance or some other form of payment. Other special interests only want to take care of their groups. Unions want to take care of union employees, and employers will provide less and less health insurance for their employees because they get a tax credit. Because they couldn't give people salary increases during World War II, so the government said, well, you can pay for their health care, and that'll be a substitute for giving them wage increases. And so that tax credit gives employers, I don't know, $86 trillion worth of tax credit that if we all just paid for our health care instead of our employers, it would change the way things look. The other thing, the special interest involved, that the healthcare industry treats healthcare as a commodity, not as a social good. Healthcare is a social good, but it takes money to get healthcare. And a lot of people don't have it. Second reason, and this is where the book by Altman and Shachtman come in, the failure of political negotiations. And Obama is right in there with the other failures of political negotiation. He looked at what happened to the Clinton health care plan, and the Clintons' plan to provide universal access to health care was cratered by the insurance industry. So Obama said, okay, well, we'll make it health coverage, and everybody will have insurance. And there's some good things in the Affordable Care Act, but the bad thing about it is that it's all about insurance. It's not about access to health care. You may have noticed that in Congress, political negotiations aren't too friendly these days. Well, don't leave out the Supreme Court. The Supreme Court made a ruling that allows Texas not to expand Medicaid. It's up to the states to decide whether they want to participate in the expansion of Medicaid. And so the plan that Obama's people had for expanding Medicaid to cover a large number of people otherwise ineligible only works if the states will agree to it. And you may remember that the governor of Florida and the governor of Arizona came out in favor of expanding Medicaid, but their state legislatures nixed it. They don't want to do it. Third reason, the escalating costs of health care in a technological era. Most Americans favor universal access to health care, but they don't want to pay for it. And it would cost a lot, because we spend a ton of money. Look at what percentage of the gross domestic product is spent on healthcare. Approaching 20% of our gross domestic product. We spend way more on healthcare than all of those other countries that have universal access to healthcare. Because we love our technology. Our left ventricular assist devices and our artificial hearts and all of the other things that cost fortune, not to mention the way we keep people alive at the end of life in intensive care units, or even if they're in vegetative states. So if we were going to have universal access to health care, we would have to do something about the costs. The Obama administration is doing something about the costs by cutting what they're paying in Medicare, but that's just making the doctors and the hospitals extremely anxious and unhappy. Most importantly, we lack in the United States a national, state, or community solidarity. We just don't have it. Some states, Hawaii and Minnesota, are a lot closer to community solidarity, and Hawaii does have a universal access to health care program. Amish communities have solidarity, because they don't believe in insurance. My father lived in Indiana for a number of years. He was a veterinarian. He dealt with the Amish, and I got to know some of the Amish people. I was talking to them about this. If somebody gets sick, they go to the hospital, and the Amish pool their money, and they pay for it. They have community solidarity. They wouldn't pay for me, but they pay for members of their community. And we see this occasionally. We see communities rally around individuals or families that have special needs. But as a nation, no. The Europeans, and as you pointed out, France at least is explicit about their solidarity, but it's also common in other European countries. In the United States, this is the fifth reason, we really are libertarian individualists. Come on, listen to the things that we find just in popular speech. Every person for themselves. pull yourself up by your own bootstraps. Heard that in Texas? You're on your own. Fend for yourself. Protect your self-interest. Your health is your responsibility. Let the free market regulate health care. Health care is treated as a commodity. Sixth, I grew up in the Midwest in a small town in central Illinois. I can tell you that I grew up with a huge distrust of government. I mean, Chicago. Who comes from Chicago? Do you trust government? The old saying about Chicago, you vote often as long as you get paid. Early and often, as long as you get paid. We have government programs, but I mean, take our illustrious governor who doesn't want to participate in Medicaid because it's a broken system. Right? He's willing to spend $3 billion on cancer research where the money wasn't going to the researchers, going to the people running the research program. To the credit of the Houston Chronicle reporter Todd Ackerman, they blew the whistle on this sham. The legislature investigated it, and now they're going to restart it, and I hear that the lieutenant governor is thinking of reappointing the same crooks that were on there before. No wonder we distrust the government. We should. We should hold them accountable. There's no question that there are many forms, number 7, many forms of discrimination. I can't disagree with Professor Randall, but they're not just African Americans who are subjects of discrimination. There are lots of different people who are disenfranchised, who are poor, who are stigmatized in the United States, and they don't have access to health care. But they don't have the same sort of history that we have in the United States in the way in which we treat blacks. I agree. Number 8, there's no consensus about what universal access to health care means, so I'm going to make an effort, in conclusion, to tell you what I think universal access to health care in the United States ought to look like. And I disagree with Robert Sage, who I quoted earlier, who says, gives you universal access to everything. That's not possible, it's not realistic. So, what would be minimal universal access to health care? Well, I wouldn't reject EMTALA, but, you know, that's really not where we need the most help. Everybody should have access to a primary care health professional, a physician, a nurse practitioner, at least. And everybody should have a medical home where they could go when they had a problem. Most of us don't have to go to the doctor all the time. Most of us, if we're lucky, we don't have to go very often at all. But for people, when they're sick, it's much better to do something about your health problems at the earliest possible stage. And if you had a primary care system, like they do in the Netherlands, for example, that would go a long way to solving some of our problems. In Amsterdam, the doctors all have a neighborhood that they take care of. And a family physician is available to anybody in that neighborhood. We'd have to make allowances for the way in which people are distributed in the United States. But it's possible. When I was in California, I was part of the Kaiser healthcare system. It was fantastic. If you were a member of Kaiser, 24/7 you could go to the Kaiser hospital with whatever your problem was and somebody would be there to take care of you. There were doctors on call 24 hours a day. The doctors at Kaiser were paid salaries, so they only worked 40-hour weeks. Anything you needed could be evaluated and you could be taken care of. And you paid for it, but you had universal access. There's no reason that we couldn't have systems like that here. and I'll suggest some of the ways in which it could be achieved. One of my colleagues in the public health area has suggested that what we need are public health corps of physicians. I mean, a little bit like the VA system was in its early years, where if you were a veteran that was qualified, and in fact, in the early years, all you had to do is have served in the military. You could go to the VA, and there would be somebody there to take care of whatever your needs were, from primary care all the way through. Well, maybe that's not feasible to have the complete access to health care that Dr. Sade talks about. But surely we could have primary, preventive, and chronic care all built into the primary care system. And good family doctors in the Netherlands will take care of people from birth to death. And they'll have a whole set of patients that they'll take care of. Wouldn't that be nice? We may not be able to achieve that, but we could certainly aspire to it. But you know what? I teach medical students. It's very hard to get medical students to go into primary care. You know why? Because they're the lowest paid doctors. We've created a generation of people who, unfortunately, often go to medical school and end up with a debt load of $100,000 or more, and so they want to go into cardiothoracic surgery or neurosurgery or some other kind of surgery. I don't blame them. But what we should do in this country is finance medical and nursing education for people who are willing to go into primary care and give them a free education. And it would cost a lot less than the costs that we incur when people end up in the hospital when they could have been taken care of by a primary care physician or a nurse practitioner. Although I must say, I wouldn't want to get into an argument with some nurse practitioners. They scare me a little bit. They probably scare, some nurse practitioners probably scared the doctors in those community clinics too. Because I doubt that you were any less of a outspoken, rightly outspoken critic than you are now. What we need are more people who are willing to speak out and be critical. One of the problems that I see is, and it's what I call the Obama syndrome, trying to get everybody to be nice. Well, you know, people aren't always nice, and some problems require something more than just kind of talking about it or offering aspirations. Second part of what I would recommend is mandatory health education. How many of you in your early education or even in your university education have actually had a decent course in health education? Only a few. Well, I'm thankful that there's some of you have, because of the several hundred people here, I saw about 20 hands. There's another one, 21. It's very difficult to get good health education. I mean, you can't rely on Dr. Oz. You can't rely on the internet. You can't rely on Wikipedia. The health community has failed us in focusing on sort of complicated medical problems without building into education from early on how to take better care of your health. 50% of the problems that have serious medical problems are a result of individual behavior: smoking, drinking, driving if you're 16, driving a car. Let's face it, we do need to do something about reckless behavior on the part of people that put themselves at risk. How would this be funded? I'm with Warren Buffett on this. We need to raise the taxes on the very rich people. I mean, I saw what the hedge fund people are making. They are not paying their share of taxes. I make a decent salary. I should be paying higher taxes. People that have a lot of money should be paying higher taxes. We could do this. We could not spend money on wars, and we could spend it on health care. Do you realize how many trillions of dollars have been spent on war in the last couple of years in bizarre war situations? So it would require, as a matter of practical action, a revolutionary way of thinking about who do we owe a debt to in our society? Who should we be taking care of? At least the people who are sick. We don't even take care of the veterans that come back from the war. I mean, every day in the newspaper and on the news, you find that, and I actually have a student who's just come back from military service. He's writing about the way in which the military excludes people from care because they don't want to pay the money for people with post-traumatic stress disorder or traumatic brain injury. It's scandalous. The VA used to be a system that really took care of veterans. Now it's how to keep from getting them in the system. So it's not hopeless, but it's going to require the kind of collective community engagement that you were talking about and the passion that you displayed in talking about racism. I mean, we need to have that kind of passion, not just for ourselves, but for other people. Because we are all equal. We're all vulnerable. And since we're all vulnerable, we need to take care of the people that are most in need. So maybe the idea of the neediest first is really a good idea. And we really do need to do that, but our healthcare system doesn't even begin to move in that direction. I'm not saying that this is something that could be done overnight, but we do have a few years ahead of us. We're going to have to do more than just have the Affordable Care Act. Professor Randall has mentioned some of the problems with it. I see the entire concept of the Affordable Care Act to be problematic. We should start with the people that most need the help and work our way up rather than take care of. The people who work for the government have the best insurance of all. My father worked for the Department of Agriculture, and when he had a medical problem that would have cost him $500,000 if he had to pay for it, Blue Cross paid for it. They didn't pay $500,000, they ratcheted it down. But yeah, the world's best insurance. The senators and the representatives in Congress, they have great insurance. If we wanted to have insurance like that for everybody, that would be a different story. But we don't. We have a long way to go. I've tried to give you a picture of what a maximum universal access to healthcare system would look like. That's unrealistic, but we need to aspire to get people the care that they need as soon as they need it, and that's by having primary care, preventive care, health education, and chronic care available to everybody who needs it. Thank you very much.